Today we're going to be looking at type 2 diabetes mellitus, which is a condition which involves too much glucose in the blood. Now, before we have a look at diabetes itself, it's important to understand the pancreatic physiology first. So if you remember, we have our pancreas, and this has multiple exocrine and endocrine functions. And if we zoom into a particular region of the pancreas, we can find the islets of Langerhans, which are composed of different cell types. We have our beta cells, which secrete insulin. We have our alpha cells, which produce glucagon, and we have delta cells, which secrete somatostatin. And these different cell types and different hormones can all help to regulate blood glucose and other chemicals in the body. If we take a look at insulin in particular, what happens is that when we have a high level of blood glucose, it triggers the pancreas, and more specifically, the beta cells of the pancreas, to secrete insulin. And this insulin can help to reduce blood glucose levels via two main mechanisms, the first being increasing glucose uptake. And what happens here is that insulin binds this receptor, and this triggers a transporter called GLUT4 to fuse with the cell surface membrane, thereby allowing glucose to enter the cell via the GLUT4 system. The second method involves increasing glycogenesis. And again, insulin binds this receptor, and glucose enters the cell. And when it enters the cell in this case, it fuses with other glucose molecules to form a long chain of glycogen, and this is useful for glucose storage. If we take a look at the condition in question, type 2 diabetes involves resistance to insulin and forms around 90% of all diabetic cases worldwide. And as a result of this reduced insulin sensitivity or resistance, there's increased levels of glucose in the blood and decreased levels of glucose in the cells. And we can use both of these changes to work out the signs and symptoms of type 2 diabetes. Okay, so with less glucose being present in the cells, there's going to be less glucose available for metabolism, resulting in decreased energy production by cells. And this can cause symptoms such as weakness and polyphagia or increased hunger in patients. With more glucose being present in the blood, the high glucose concentrations can drive glucose into the urine, and this results in the first sign of glycosuria. With more glucose being present in the urine, water molecules, or H2O, also get dragged into the urine via osmosis, resulting in polyuria. And with more water being lost in the urine, patients may experience dehydration or increased thirst, which is also known as polydipsia. And these four changes form the core symptoms of type 2 diabetes. Aside from the core diabetes symptoms, patients with type 2 diabetes may go on to develop diabetic complications, which can be divided into microvascular complications and macrovascular complications. So looking at microvascular first, potential complications can include diabetic retinopathy, which results in worsening vision and potential blindness if left untreated, diabetic nephropathy, which can cause problems with the kidneys such as chronic kidney disease, and diabetic neuropathy, which often presents with neuropathic pain and reduced sensation or numbness. In terms of the macrovascular complications, patients with type 2 diabetes can develop coronary heart disease, which involves atherosclerosis and acute coronary syndromes. There could also be congestive heart failure, which involves high blood pressure and edema, as well as other symptoms. And in some cases, cerebrovascular events may occur, which include strokes and transient ischemic attacks. And it's worth noting that the whole purpose of type 2 diabetes management is to prevent these complications from arising, and it's for this reason that regular monitoring for these patients is required. For the diagnosis of type 2 diabetes, the mainstay involves measuring HbA1c levels, which are a good indicator of long-term glucose control. Values above 48 millimoles per mole or 6.5% are often indicative of the condition. Blood glucose can also be measured, with different cutoff values depending if it's a fasting plasma glucose test or a random plasma glucose test. And in some instances, the oral glucose tolerance test can be performed, where glucose is administered to the patient and levels are measured after 2 hours to see the response. It's worth noting that if patients are asymptomatic, a repeat test should always be performed to confirm the diagnosis. In terms of the management of type 2 diabetes, the first step involves addressing lifestyle changes, as well as making sure that blood pressure and lipids are within normal limits, as this helps to reduce the occurrence of diabetic complications. For more specific management, Metformin is usually the first-line medication used for the condition, and target HbA1c levels of 48 mmol per mole are used for guidance. Other diabetic medications might also be considered, such as sulfonylureas and SGLT2 inhibitors, and we usually add these if HbA1c levels increase past 58 mmol per mole. And finally, insulin might be considered if other treatment options fail. Okay, just to look at the treatment pathway in more detail, let's imagine a patient who's recently been diagnosed with type 2 diabetes. The first step of management should always be to offer lifestyle changes, such as stopping smoking or improving your diet. If despite these lifestyle changes no effect is seen on the HbA1c values, then at this point you would consider starting diabetic medication, such as metformin. After trialing metformin for some time, if the values remain between 48 to 58, you would consider increasing the metformin dosage. But if the values creep above 58 mmol per mole, then you would consider adding a second diabetic medication, and you can see the different combinations which could be offered here. If despite a second diabetic medication, HbA1c values still remain above 58 mmol per mole, then you would consider adding a third medication, and again the different combinations can be seen here. Note that metformin and insulin can sometimes be used instead of a triple therapy for the third line management. If metformin is not tolerated, you can move straight to other diabetic medications instead to ensure optimum glycemic control. Just to finish off, we have a quick clinical case here. A 63-year-old male presents to general practice following a recent diagnosis of type 2 diabetes. He has already been offered lifestyle advice and his blood pressure and lipid levels are normal. His HbA1c is measured to be 50 mmol per mole. What is the next best step in this patient's management? So in this case, the patient should be started on metformin, as the values are above 48 mmol per mole despite adequate lifestyle advice. As a follow-up question, the patient visits his general practice for another appointment 4 months later. His HbA1c is now measured to be 56 mmol per mole. What is the next best step in management? So for this question, because the values lie between 48 mmol per mole and 58 mmol per mole, the metformin dosage should be increased. If the values were to increase beyond 58 mmol per mole, then you would consider adding a secondary diabetic medication, such as a sulfonylurea. And here we have a summary slide outlining everything I've gone through in the video. If you have any questions, please leave them in the comments, and I'll see you in the next video.